Our next speaker is Dr. G. Parameshwar. He's Emeritus Senior Consultant Anesthesiologist, at present working at Manipal Hospital, Bangalore. He was a secretary of SAC, Association of Anesthesiologists. He was past governing body member of ISA and past secretary and president of ISA and NACC. He has lot of publications and delivered many national and international lectures, almost about 150 lectures. So I welcome you, sir.
Brain swelling. Brain swelling, there is Mysore. At the outset, I must thank the chairperson for having been introduced. Thank you very much. Also, that I would like to thank the organizer for giving me this opportunity to talk about some of the common problems during the neurosurgery. Now, that is one of the commonest problem we encounter is the intraoperative brain swelling. And now, this was coined, the word brain swelling was coined by Haynes and Slocum in 1962. What does it mean? Basically, that it is a swelling or the tightness of the brain when you open the craniotomy and the dural flap is reflected. You may also call it as brain relaxation. Either way, it can be used interchangeably, which is opposite of brain swelling. Wait, the important point of that, why we are so much concerned about that is that it interferes with the surgery. There may be difficulty in retraction, injury to the brain, and may cause ischemia also. And therefore, both it has anesthetic as well as a surgical importance. I am not going to talk about ventricular hypothesis. Already it has been explained by previous surgeon in detail, except that this is one of the reasons as the tumor size or the hematoma or whatever the intracranial component increases, we may have increased intracranial pressure. And one point I would like to highlight is that this pressure volume curve we are all familiar, but in children they have less compliance available, so they can go in for herniation much more rapidly as compared to an adult or elderly patients. There will be generally some degree of relaxation, basically because there is the brain volume start decreasing in older patients, so they have some more compensation available for that one. So basically, as the pressure starts increasing, there can be focal ischemia, and if it reaches beyond 60 millimeters of intracranial pressure, you can go in for global ischemia as well, and then herniation. Now here, I would like to make a differentiation between a brain swelling that is and its relation to the intracranial pressure. Now when we know that when we open the cranial cavity and open the dura, the intracranial pressure falls to atmospheric pressure. So we can't measure the intracranial pressure at that time. Intracranial pressure is the pressure within the cranial cavity. It is a pressure. Whereas when we talk about brain swelling, it is a volume content. So when you open the, if the volume is increased, as soon as we open the cranial cavity, it herniates. So that is the difference between brain swelling and intracranial pressure. And intracranial pressure generally is measured, we all know that it is, you can measure by intraventricular, subdural, all the measures. So its ICP is a objective measurement, but whereas brain swelling is a subjective, in the sense some people may find that the swelling is not that tight, some people may find it is very tight. So it is different, slightly it's more objective, this thing. Now how do you grade this brain swelling? Now one of the simplest method is you can say that in a brain it's more of a relaxation. So very good relaxation, some minimal relaxation but acceptable swelling, or there is some severe swelling but there is no need for any other require interventions, and of course the severe brain swelling as we have seen in here. However, we have used a little more objective method in NIMHANS when we are doing there. So we called it as grade 1, 2, 3, 4. Grade 1 is that brain is very well retracted. There is enough space between the cranial cavity and the surface of the brain. And the grade 2, the surface of the brain is almost near the cranial cavity, but there is still sufficient space available for the tongue. That is grade 2. And grade 3, it is at the level of the craniotomy, and grade 4 of course is well above the craniotomy, and the pulse at that point of time the pulsation starts ceasing. Now what is the incidence which get? There are many studies, not many studies which have shown the incidences, but one of the earliest studies which by Rasmussen has shown that the incidence is somewhere between 5 to 6%. So they had about 692 patients in a group where 8% had excellent relaxation, 55% moderate relaxation, and 29% had a moderate degree of brain swelling and 6% brain swelling. So severe brain swelling about 6%. If you include the moderate degree also, it comes to about 30%. They also had a study where they measured the subdural pressure before opening the dura. And if they had the subdural pressure of about less than 5, the probability of brain swelling is less, about 5%. Whereas if it is more than 13, definitely there is a brain swelling is going to be there. And 26, there is going to be what is called as a malignant brain swelling. So what is the etiology? We all know certain tumors, certain head injuries do cause severe brain swelling. So the brain's tumors such as high-grade gliomas, such as meningioma generally do not cause so much of swelling, but nevertheless meningoepithelial meningiomas and some deep-seated tumors, basically when they are being manipulated, they could cause severe edema. Infections can definitely cause abscesses, tuberculosis, cystic sarcosis. Head injuries invariably cause severe brain swelling. Aneurysm bleedings, then certain cerebral metabolic diseases, Ray's syndrome, liver failure, etc. As far as the vascular disease is concerned, we also have to keep in mind hypoxia, hypercarbia, hypertension, hyperthermia, and seizures. All these things are likely to cause vascular diseases, brain swelling. And high venous pressure, such as because of coughing, training, high airway pressure, PEEP, head down tilt, twisted neck, cardiac failure, cerebral venous thrombosis, etc. They are all cause brain swelling. Which are the factors that influence the brain swelling? We had a study at NIMHANS as early as in 98. We found that the presence of midline shift is most important. The tumor size is not important for brain swelling. In spite of big tumors like meningioma, there could be still good relaxation. If there is a presence of peritumoral edema, yes, they are going to have brain swelling. If there are obliteration of basal systems in CT or MRI scans, definitely there is going to be a severe swelling. And clinically, if the patient had a severe headache, papilledema, and is altered sensorium or impending herniation, he is likely to have brain swelling. Similar studies have been done recently. This one has shown that what we had a midline shift, which is there. If there is a midline shift, there is a mass effect. If there is a peritumoral edema, and use of dexamethasone decreases the brain swelling. Peritumoral edema, all these things, same factors have been there. This is a recent study in 2020. Often we come across a good relaxed brain. Suddenly the patient, the swelling starts, the brain starts swelling. What could be the causes? In maybe there is some bleeding, hematoma formation which may be below the tumor, or it may be even on the contralateral side which may not have been recognized, or it could have caused some ischemic event because of some some blood vessel has gone. Traumatic brain injuries and hypotension during the surgery might also cause severe brain swelling. So how do you manage all these things? First of all, we have to have some general measures we have to see. As we know, the venous pressure is one of the important aspects of brain swelling. We have to correct the head down tilt if there is anything. It's better to elevate the head up to about 15 to 20 degrees, which causes displacement of CSF. And however, a very high degree of CSF head elevation may also cause pneumocephalus or even venous aortic embolism. We have to keep it in mind, that one. So how to decrease the cerebral pressures? Correction of twisted neck, what we have to correct it. make sure that there are no compression on the neck veins, air pressure monitoring by keep the air pressure within certain limits, PEEP, change to pressure control if it is air pressure is high, prevent coughing, straining with adequate muscle relaxations, and of course the most important aspect is decompress the tumors or hematoma. So the general other measures which I have to keep it in mind is that often we use vasodilators to decrease the blood pressure to keep it high. So they like nitroprusside, nitroglycerin, they can cause a brain swelling. Make sure that there is no hypoxia, hypercarbia, hypertension, and if there is a severe hypertension beyond the autoregulation, we have to correct that. Hypotension can cause reflex vasodilatation, and pain, agitation, vomiting, shivering, intraoperative conversion, they can all cause severe brain swelling, which is more important during awake craniotomy and may interfere with the cerebral mapping. So we know that one of the important aspects of the blood pressure has been already discussed now, hyperventilation or the carbon dioxide levels. Hyperventilation reduces cerebral blood flow, volume and ICP. PSCO2 between 25 to 28 measure decreases cerebral blood flow by about 50% at the rate of about 1 millimeter decreases 2% cerebral blood flow, and one should not reduce to PSCO2 beyond 25 millimeters as there is no further decrease in the cerebral blood flow. Intraoperatively, acute hyperventilation is for a brief period is very good in reducing the brain swelling, particularly in tumor patients. However, prolonged hyperventilation can cause ischemia and should always be avoided in patients with head injuries. And one of the studies has shown that long-term patients with long-term survival, those who have hyperventilated has lower lesser outcome than those who did not have hyperventilation. So this is one of the factors which should be kept in mind, that unless it is necessary, hyperventilation should not be instituted. So how does hyperventilation improve operating conditions? Now this is a multi studies which include the American, our NIMHANS, and All India Institute and other things, has clearly shown that in craniotomy, when the tumors, if there is a hyperventilation, the cerebral blood flow actually is less, and when they are returned back to normal ventilation, or then actually the ICP increases. So this is the study by multi-center study, including Dr. Parameshwar, who has there this one. Then the next point is, apart from the hyperventilation, hyperosmolar agents are the most common agents which are used, and they generally translocate the fluid from extravascular to intravascular fluid. They decrease the viscosity and thereby can increase cerebral blood flow. They act on the normal brain tissue. They don't act on the tumors or hematoma. So it is the normal brain tissue which reduces in size, and very severe shrinkages might actually cause herniation, but however they are very known to cause electrical imbalances. They can precipitate a renal failure and may increase the blood volume, particularly mannitol, and can precipitate cardiac failure. So we have 20% mannitol, 25% mannitol, 0.9% sodium chloride, 3% sodium chloride, which is commonly used, and also 23% sodium chloride, which have a different osmolality varying between normal of about 300 for the sodium chloride. Mannitol produces about 1098, and sodium 3% sodium is about 1026. However, there is a problem. Rapid correction of the osmolality can cause brain injury. Sudden drop in the osmolality actually leads to brain swelling of the astrocytes and particularly lead on to swellings. Seizures can be initiated and they become extremely excitable tissues. In extreme cases, like downward displacement can cause into the meninges and foramen can cause herniations, and elevated osmolality can cause brain sickness, and then it can cause reverse coning. Herniation to foramen magnum can be dangerous, and rapid correction can cause demyelination problems, particularly in the pontine structures, tegmentum, thalamus, putamen, caudate nucleus. So reduced brain volume can stretch the cortical vessels also and can cause subdural hematoma. So this is the problem of rapid correction of these things. So coming to mannitol, it's commonly used. You use as 20% solution varying between 0.5 to 1 milligram per kg body weight. It produces significant diuresis, can produce severe hyponatremia, hypokalemia. Is very effective in reducing the brain swelling in brain tumors, and it's directly dose dependent on that one. It increases microvascular flow, reduces the peritumoral brain edema surrounding the tumors and abscesses. For its best effect, you have to give it about 30 to 45 minutes before bone flap, and it has a minimum metabolism and rapid excretion. However, it is less effective in patients with brain trauma, with the intracerebral hematoma and strokes, aneurysm bleeds, and if there is a brain barrier disruption, it can paradoxically cause edema of the brain tissues. Now, hypertonic saline is available 3%, 7%, 23%, may be given as IV boluses, and is more useful in patients. It does not cause diuresis, and doesn't cause any volume depletion. More useful in patients who have hypovolemia and hyponatremia, of course. And more useful in head injuries. You can see this graph. This central venous pressure is well maintained with hypertonic saline than with mannitol. However, it requires a slow correction. You can't give it rapid bolus dose like mannitol. You have to give it a bit slow at a rate of about 75 to 100 ml per hour, at rate of 1 ml per kg per hour. However, therefore, it's not very useful if it is in a tumors, because you can't give it as a rapid this time. It can cause hypernatremia, hypokalemia, and rapid infusion can lead on to central pontine myelinosis, congestive cardiac failure, pulmonary edema, and also coagulopathy in higher concentration. So the mechanism of clinical effects in the mannitol versus hyperclinic is that they increase the gradient across the blood-brain barrier, and therefore decrease the ICP. Mannitol has longer effectiveness, longer duration as compared to hypertonic saline. So the mannitol can cause vasodilatation and decrease viscosity and increases blood flow, whereas such a thing is not there with hypertonicity. Hemodynamics are basically very similar, and mostly the mannitol is almost impermeable, as well as the hypertonic saline. However, adverse effects are much more with mannitol, like kidney injury, dehydration, hypotension, electrolytes imbalance, monitoring. It can cause osmolar gap, electrolyte disturbances, whereas hypertonic saline basically causes demyelination. So if you compare hypertonic saline with mannitol in brain this is a study from All India Institute. There is no hemodynamics as far as they are concerned. They are very similar. If you compare this is a study from PGI Chandigarh, where they had used mannitol and compared with the hypertonic saline, and they found that there is not much significant difference, except that there is a unit output is more with mannitol, of course, and there are sodium changes and potassium changes are more with mannitol as compared to hypertonic saline. There is a similar study which is also shown that this is in traumatic brain edema patients. If the mannitol has a longer duration, and patients require more number of stay in the ICU as compared to those who had received hypertonic saline. And similarly, another equimolecular doses when they were used, it was found that the mannitol produces higher degree of maintains higher ICP as compared to hypertonic saline in patients with brain injuries. The next dose which I have been using is furosemide. It has been used earlier, but it is not all that effective or given alone. However, one might use it with mannitol But one of the studies which has been shown that the mannitol along with furosemide did not really influence much of the intracranial pressure. So one might use just mannitol alone. Just for completion's sake, glycerol is not available now, but we used to use earlier as one of the IV agents to decrease the intracranial pressure. However, glycerol is being used for maintaining the for given orally for maintaining the to reduce the intracranial pressure. Steroids are most important when they reduce the periteromeral edema and maintains the vasogenic prevents the vasogenic edema. They reduce stabilizes the tight junction, promote sodium potassium movements, and dexamethasone is the drug of choice which is more potent than the prednisolone. Can be given intraoperatively, preoperatively, and may cause hyponatremia. Steroids are useful in reducing brain swelling in tumors, particularly abscesses and metastasis. However, not very useful in reducing the traumatic brain injury, stroke, and aneurysm bleeding. In fact, it is contraindicated in a patient with brain injury due to trauma because it decreases immunity, increases the mortality, increased incidence of respiratory complications such as pneumonia, ARDS, and increased incidence of extracranial complications also. We all know about the effect of anesthetic agents already. The previous speaker has shown, except that I would like to point out that the context sensitivity time index is lowest as far as the propofol and etomidate is concerned and highest for thiopentone. So, any infusion is given, it's better to give propofol or etomidate. And if you compare the agents, in one we compared in this one thiopentone versus propofol in our Manipal hospital, and we found that the propofol is more effective in causing a better relaxation as compared to thiopentone. A similar study has been done by other studies also in anesthesiology, and when compared to propofol fentanyl and isoflurane fentanyl anesthesia, propofol fentanyl appears to be much better as compared to isoflurane alone. CSF drainage is another one which is often used for pituitary surgeries, to the transpyramidal surgeries, and helps in removing the. It can also be used to know the limit of the tumors and helps in drainage of the CSF in the post-operative period. And you should keep it at about 10 to 20 ml per hour, not more than that one. Surgical decompression is the last method which is available when all other measures have failed. So basically that you can increase the size of craniectomy or do a lobectomy in the non-eloquent areas, and in patients with vascular lesions they are more effective, and it has been found that surgical decompression craniotomy is decreases the mortality. So indication is basically that if there is a patient is more than 50 years and there is severe swelling in the CT scan, fatal brain injury is there, and refractory intracranial hypertension not reactive to other things, there is electric deterioration in electrophysiological factors, and there is also what is called as controlled decompression. You suddenly don't decompress, you decompress the ICP slowly over some time. That is supposed to be more effective than regular decompression. So the management basically starts with the general physical prophylactic measures, and then you go in for resection of the tumor, like then use hyperalphamolar solutions. If still not competent, then go for hyperventilation. You have hypothermia, barbiturates, other things. Lastly, you have the decompressive craniectomy. So it is not very uncommon to have intraoperative brain swelling, and many of them do have mild to moderate degree of swelling. However, severe brain swelling requires a decompressive craniotomy as for this one. Severe brain swelling increases the mortality. Thank you very much.